Welcome to Speaking of Pets, Take 2.
This week, we are revisiting a previous episode.
Lots of great information. We wanted you to enjoy it twice.
Here's today's episode, created just for you and your pets.
Hey everyone, welcome to Speaking of Pets. I'm Dr. Alice Novotny-Jeroman, a board-certified veterinary dermatologist and allergist, and
I'm Janet Novotny-King, and I am not a board-certified allergist and dermatologist. I'm the sister.
Janet, guess what? We have a dynamic duo with us today. First of all, I don't know if you all remember our favorite board-certified veterinary dentist, Dr. Sharon Hoffman. She was on the podcast a few segments ago, and we had so many comments and questions about dental care and oral health care that we decided to have her back, which we're very happy she could join us today. Just to refresh your memory, Sharon is a board-certified veterinary dentist, as I mentioned. She's a diplomat of the American Veterinary Dental College. She received her DVM degree from Louisiana State University and is the owner of Veterinary Dental Consulting in Florida, where she is also on the faculty at the University of Florida College of Veterinary Medicine. Our second part of our dynamic duo is Dr. Carolyn McKune, who is a Michiganer. She's a Spartan. She received her veterinary degree from Michigan State, did a year internship at Washington State University, then a residency in anesthesia and critical patient care at UC Davis. She became boarded in the American College of Anesthesia and Analgesia in 2009, was at the on the faculty of anesthesia at the University of Florida, and then launched her own independent veterinary anesthesia consulting service, Mythos Veterinary. She also served as a chief anesthesiologist and medical director at a local specialty hospital, but found that she really liked working on her own. So right now, she is the owner at Mythos Veterinary and provides veterinary anesthesia in both physical and virtual anesthesia ways, which is really cool because people don't know that most veterinary practices do not have a boarded anesthesiologist available. So Dr. McKune can provide those services virtually or in person. And what's really cool about Dr. McKune and Dr. Hoffman is it's a wonderful specialty that complements each other, because we know that for perfect oral and dental care, you need general anesthesia. So we can't wait to go over so many things that from client concerns about anesthesia to Dr. Hoffman talking about more about oral and dental care. So thank you both for joining us today.
You're welcome. Glad to be here.
Yes, thank you very much, Alice and Janet.
It's our pleasure.
Janet, why don't you start with some of the questions that we had from viewers?
Well, I have to say, I got my teeth cleaned this week, and I wish they would have knocked me out. They put that pink topical stuff on my gums. It was the first time this has ever happened to me. I literally because you couldn't. It was bizarre. And then she's in there digging with the pink stuff. It was awful. So, all our typical pet owners, I hear this from all my friends. I got to go have my dog's teeth scaled or cleaned, and they're going to knock them out. Is that okay? So, can you just talk in general about the safety of anesthesia and the need for it with dental care?
Sure. So we can go over a few things from the anesthesia side. One, it's very helpful to have a veterinarian who's the primary veterinarian. So your anesthesiologist will never be your primary veterinarian. We need people like Dr. Hoffman to be able to consult with the client, talk to the patient, and as we'll probably go over later in the podcast, discuss some important history that is very pertinent for us to be able to safely provide anesthesia for the animals. First thing that might be helpful is kind of defining the anesthesia period, because everybody thinks of anesthesia as we might see on a television episode where a patient is laying on the table and then all of a sudden they're awake. And there is a transition time during that. And what we've actually found as we get better and better at providing anesthesia for animals, that it is equally as important in the pre-operative period, so what the animal comes into the hospital already having had, because as Janet kind of mentioned, now she might have some anxiety about the next time she goes to the dentist. The animals oftentimes also have a component of anxiety before they arrive. What happens during the anesthetic event, and then equally as importantly, what happens after the anesthetic event has concluded and the patient has started to recover. Unlike in the TV shows, they're not going to go back to being 100% normal. So we'll discuss throughout the podcast, I'm sure, some expectations that might be realistic to have for some of these animals. So anesthesia period is wide and encompassing for all of this.
Interesting. So, Dr. Hoffman, why is it? I mean, clearly you can't clean a pet's teeth while they're awake.
So there's a difference between what the groomer does, and there are some non-anesthesia practitioners scaling the teeth with the pet awake. That can be done in some patients, but not all. And what's missing is a thorough exam. Dental x-rays can't be taken, exam around each tooth and under the gum can't be performed. That can't happen. So yes, anesthesia is required for a complete oral exam and treatment.
That's great. Thank you.
So Dr. McKune, do all patients need an IV catheter then?
Yeah, I think that that's probably a good safety point to discuss. As Janet alluded to, there are risks with anesthesia. And when we look at risks of anesthesia, some of the most common anesthetic risks are either from problems with your heart or problems with your lungs. And if we have an IV catheter in place, we can administer drugs to be able to help support some of those processes, or we assist the patient with being amenable to having whatever procedure they need to have done. So the IV catheter access is important and critical if there is an emergency, and then very helpful during the entire anesthetic period.
So, what are some common myths about anesthesia for your pet?
Yeah, so we have several patients that present to us in a wide variety of shapes and sizes. And so one of the things, it surrounds patient size, and there's thoughts that maybe a patient is too small to be anesthetized. And from the workflow perspective, it is challenging when you have quite a small patient to do some of the routine things like the IV catheter placement we were talking about. They're very tiny. You need to have the appropriate sized equipment to be able to support them. But it's not an anesthetic contraindication to be small. And so being a smaller pet does not put you at any increased risk, as long as we're respectful of the fact that any anesthesia carries concerns for patients. And so we want to appropriately provide the right dosages for medications. We want to make sure we're providing heat support, especially for the little guys. And then we want to make sure that we've got the right equipment to be able to support their small size.
Yeah, some of my patients come in purses. They weigh less than a gallon of milk, but they need the care, and so there's a lot of myths. There's a lot, and when I hear fear, if someone's coming with a fear or a dread, is like they think an anesthesia event is going to bring their pet closer to death, and each time they've had anesthesia, they're getting closer and closer to death, and that they want everything done for the whole pet, mouth, ears, everything under one anesthesia, because an additional anesthesia is closer to death. And so Dr. McKune will often talk to patients, the clients, the pet owner, and I'll be in the room, and she has a good way of getting them over that dread hump, is what I'm going to call it.
Wow. Well, what actually happens to the pet when they're put under? I mean, I've been put under for procedures, but they're in sort of a sleep zone, right?
Yeah. So there are 5 important components for a patient to be considered anesthetized, human or animal. We need to have the right pain control, and so they have to have pain medications as part of this, which is something your veterinarian might ask you about providing for the animal, because there are obviously financial costs for doing that. We want to try and make sure that patient is unconscious. And so a good way to think about this is, when you're sleeping, if you were to roll over on something sharp, you would still move away from that, right? You would still, even if you weren't conscious, you would still have movement. And so although a lack of movement is important, a true unconsciousness is also important. So there is going to be the analgesia, the pain control that we're talking about, or a patient who's not conscious, and a patient who does not move, a patient who has muscle relaxation. So their muscles are very soft and easy for them to be positioned as they need to be. And then to try and make sure that a patient has amnesia. That is a very hard thing to quantify in an animal, that they would have amnesia, because they're not verbal responders. And so just like children, nonverbal children, that they can't tell us if something has happened. So that we speculate on in veterinary anesthesia, but having those 5 components is what characterizes a patient who is anesthetized in an ethical and moral acceptable state for an intervention to be done.
Well, and you mentioned pain management. Why is that so important? How do you define pain management, and why is it important for our pets?
Yeah, no, that's a great question. So, pain is a sensation. If we look at the kind of broad definition that's accepted for pain, it is a real or emotionally perceived sensation, either in response to or in actually experiencing an event. That's considered pain. So, an animal or presumably a human can anticipate something that's going to be unpleasant and actually go through pain and discomfort. And what that means for us is that we should be preemptive about anticipating that there is going to be discomfort with any kind of intervention that we make. That's what we would call an invasive intervention, where we're actually going to be providing some stimulus to those things. And so, since we know that that's coming, and we know that there can be such a broad definition of pain, it's a better idea for us to do as much as we can to mitigate that before the pain occurs.
I've had owners say to me, "Oh, I almost lost my dog. He had a bad reaction to anesthesia." I think people use the word reaction and side effect inappropriately. As a former pharmacist turned vet, people will say, "Well, I had a side effect to that." I say, well, it's not really a side effect. But can you talk about that what is quote unquote a bad reaction?
And P.S.
That they took long to wake up,
Well,
or
and P.S. when you look at like side effects of any drug, like at the end of the drug commercials, it's like a list like this. You're like, God, I'm never going to take that if I'm going to get any of it. And I
right?
think it's when they do the testing, it must be they had 1 or 2 cases of it. Do you know what I mean? But put it on the list as a side effect.
Well, it has to be statistically significant. I'll tell you that. As being part of a drug trial, which our office was,
Yeah.
and I would report something that you kind of get a little fight about it. Well, are you sure they were on an ear medicine at the same time? How do you know it wasn't that?
Oh,
You see what I'm saying?
yeah.
So when it gets put on the list, it
It's
happened.
something.
Let me just put it
It's
that way.
something.
But
Okay.
to me, that's totally different than what someone says bad
No, I
reaction.
agree.
I always want them to define that.
Yeah, and I think that that's a good point because reaction, bad reaction, or adverse reaction, or unusual anesthetic event, those are very broad terminology. It's like saying the weather is nice. For us in Florida, we may not think of temperatures of in the 90s as nice, but for somebody who's living in upper northern Canada and it's 54 right now, maybe that does seem kind of nice to have a little break there. So there's a very broad kind of concept. And so it's really helpful if we can narrow down when an owner presents to us what they mean by bad reaction. Some common things that we see, and again, Dr. Hoffman can kind of help fill in this would be taking a while to recover. And by recover, we don't necessarily mean that, they were still unconscious at the veterinarian's. We mean that maybe they didn't have the same behaviors that we would see normally, that they walked in kind of a different pattern. They were more tired than they normally would have been. They didn't necessarily have a huge interest in normal routine, like eating their food, or in some cases we see with anesthesia, a delay in the animal wanting to defecate normally. And owners are very in tune to that kind of consistent schedule for them. Other times, a bad reaction can mean that the patient was too alert and too awake and came home and seemed very stressed and very anxious. And so we can get some more descriptors on what that bad event might be. It may help us to be able to alter the protocol for the next time so that we can provide something that is more tailored to the animal's specific needs for things.
And the vocalizing during recovery or even that night. Do you want to touch on that, Dr. McKune?
Thank you. Yeah, definitely. We can see some patients who have kind of altered mental state. And in some patients, that can present as being very tired. And so they might be very sleepy. In other patients, it can present as them having a remarkable amount of vocalization. And even my own pets have had this after anesthesia where, they've been very verbal afterwards. And in dogs, that usually sounds like howling. It can sometimes be disruptive for the owner trying to be able to get some rest, or the rest of the family, or the rest of the pets that are in the household. And so those kind of vocalizations being uncharacteristic are side effects, as one might consider, if that's the right terminology, of having certain drugs during anesthesia that might be taking a little time to clear from the system.
You know, Dr. Hoffman, I remember you telling us the story about, I think it was a 17-year-old dachshund. And I can imagine that with so many years of that painful mouth, that after the procedure, I would think that a lot of your patients feel great
They feel a
in
lot
spite of
better.
the pain
Yeah.
of the
And,
extractions.
and
Yeah.
that dog, and Dr. McKune was on that case, that dog had a lot of surgery on all four sides of the mouth. And so pain management was given before the procedure, during the procedure, after the procedure. And so there's some healing to do. With that much, there's some healing, but they start feeling better right away. The pain medication's managing their pain, but it's gone in a few days, and they're doing better. And some people say, I have my dog back, or they're playing and they haven't picked up, or even a cat. We haven't picked up a toy in 5 years because they don't let us know how much pain they're in until we take the pain away.
Yes. And I think what we're kind of getting at for all of these kind of things is quality of life for animals.
Yeah.
That what we ultimately all want is not necessarily quantity of life, but quality of life. And so sometimes then that's a balance of, in the very short term, having a patient who vocalizes in the evening or who seems a little bit more listless than they would be, so that long term they can achieve what Dr. Hoffman's talking about, which is an animal who feels much more comfortable and is able to interact to a higher degree, because we didn't appreciate how much that discomfort they were living with made them not want to be a happy member of the family.
I remember, I remember one pet owner, husband and wife, I can't remember their pet, but I always call the next day after surgery to see how the pet is. I always do. And I remember the missus telling me, so-and-so, the pet is sleeping with the mister. And he hadn't done that for a long time. So the results are very rewarding, and they're very soon. And yeah, we just have to get them over the anesthesia hump, the dread hump. And we've been doing that. We get to treat a lot. And not all of these patients come in healthy. Some of them are seniors. They've got pre-existing comorbidities. But
that was my next question.
Yeah.
Yeah. And like, I would imagine it's pretty scary, Dr. McKune, if a cat or dog's in early kidney failure, yet they need that dental desperately.
Yeah.
What changes do you make to that routine for that?
Yeah, and I think a big part of that is that the wonderful thing about anesthesia is that we have a variety of options and things that we can use. The sad part of anesthesia is we only have a certain number of things that we can use. And so the drugs play a less important role, I think, than people necessarily appreciate. And so we have wonderful things that are options for us, but it's not an unlimited supply of things. So really what comes down to is the managing of that patient. And so it's that we might choose to bring that patient in early and hydrate them with IV fluids, knowing that a big part of where animals, and I guess I should specify here, a big part of where dogs get part of their water from is actually their food, whether people appreciate it or not. Carbohydrates, so half of dogs' food being carbohydration, hydrates are part of what hydrate them. And so when we withhold food before anesthesia, we know that we're withholding a water component. On top of that, when animals don't take in food, sometimes they don't have that thirst driver. And so there's a lot of reasons for even a normal patient to come in dehydrated. So if we have a patient that presents to us that might have changes to the kidney, which would make dehydration really a lot harder for the kidney to work, then we provide them those fluids intravenously before we ever start. And so we'll oftentimes make those patients the second patient of the day, not because we want to be disrespectful of the owner's schedule, but because we want that dog to come into the anesthetic period with the best level of hydration it could be, given that it already has some underlying disease.
So I bet, Dr. Hoffman, you're kind of pressured to work quickly in those older dogs or cats with the comorbidities, no?
Well, I work pretty quick because,
good.
And that's why I get a lot of referrals, because a general practitioner, and I was in general practice for 20 years, you know that, Allison. But this is all I do now, so I do it quicker. But here's the thing: when I'm working with Dr. McKune and we're a team, and I know that there's comorbidities, she's managing all that, and I'm working diligently. And I will say, well, how's the pet doing? How's the pet doing? And she'll let me know. Or she'll say, how much more do you have to do? How long is it going to take? So that if we have to stop, we can. It's not like the chest is open or the abdomen, we can stop. And that's very, very rare. The other thing that's important for the pet owner to know, that it is safer for the pet to have multiple short procedures than to have a marathon 2 to 3 hour procedure. Because the pet owner thinks it's safer just to have one anesthesia, no matter how long it is, but that's just the opposite. It's safer to have multiple short ones. So there's a lot of myths. We're debunking the myths. And it's just great to be able to help some of these that nobody else wants to help. You need a team. There's right. In our room, there's 4 people. There's me, I have a dental assistant, Dr. McKune's there, and she has an anesthesia assistant. So it's a team.
Yeah. And
okay, so I have to ask a myth. I have to ask a myth that I always hear. Like a dog's mouth is cleaner than anything. Is that true?
No.
My dog eats dead chipmunks and I don't know what else out in that yard. And I'm always like, what did you have today? You know? But everyone says it. Oh no, their mouth is really clean. And I'm
yeah, that's interesting. So let's talk about this because it's a myth. It's a big myth. And we know that there are so many bacteria in the mouth. There are thousands and tens of thousands of bacteria in the mouth. Some you can't even grow in a culture. The mouth is never sterile. The mouth is never clean. Think about what they do with their mouths.
Oh.
I don't know exactly where that came from, but you'll also hear, well, dogs and cats lick themselves when they have wounds, right?
Right.
So maybe they're clean. Their saliva is clean, and there is some homeopathic stuff in the saliva. I don't know. I don't study that, but it clearly is not clean. If you're bitten by a dog or a cat's very bad. A chimpanzee, it's all dirty. So it's interesting to know where that comes from, but I don't know.
And I bet you if we had to trace the origins, they might mean the difference truly between a cat and a dog, where because people develop infections after cat bites more commonly than they might. But really, in reality, it's not necessarily just a difference in bacteria. It's a difference in the fact that dogs provide a crushing type of injury when there is a bite, as opposed to a cat has a piercing type of injury, and then it creates an environment where no oxygen can get you, so that bacteria can grow. And so I wonder if that might be the origin. I don't know if that's the case. Maybe the cat's mouth is dirtier because if you get bit.
Even a cat scratch is nasty.
Right.
And cat scratch fever, it's a real thing.
Blue Buffalo Natural Veterinary Diets offer a natural alternative in nutritional therapy. With their in-house research and development team with over 300 years experience in well, pet, and veterinary therapeutic diets, more than 600 scientific publications, and more than 50 U.S. patents. Blue Buffalo Natural Veterinary Diets.
Hi everyone, I'm Larry. Some of you know me as Grandpa Larry. And I run Larry's Animal Safari on YouTube, where we share sweet and educational videos about baby gorillas, zoo animals, and the amazing teams who care for them. If you love animals of all kinds, I'd love to have you join us. You'll meet little ones like Jamila and Kayembe, learn how zoo families grow, and enjoy real moments that bring joy and curiosity to animal lovers everywhere. Just search Larry's Animal Safari on YouTube, or click the link in the show notes. New videos go up weekly, and each one supports awareness for animal care and conservation. Thanks to Speaking of Pets podcast for all they do. Now, let's get back to the show.
Are some dog breeds more prone to have anesthesia difficulties or oral healthcare difficulties? That's actually a question for you both.
Well, small breed dogs, we see periodontal disease more, which is also called gum disease. And large breed dogs, we see fractures and tumors. I see tumors in any size, really, but that's the older population. There's a lot of myths about different breeds. Dr. McKune has a list with greyhounds. We know they have a bleeding problem, so that's not a myth. That doesn't mean they can't have anesthesia. Dr. McKune, you want to mention some others?
Yeah. And so we can lead with that greyhound. That a lot of the work done for greyhounds was done out of Ohio State, where they looked at the postoperative, what's called delayed postoperative hemorrhage that happens for these dogs afterwards. And so they can have a very routine anesthesia. The vet can do a perfect job. And afterwards, the animal ends up in the ICU with needing critical support because of this. And so there is a genetic predisposition for that. And there are genetic tests that a person can do to try and find out more about that. And so greyhounds are definitely one we have a little more consideration of. We also have large-scale morbidity and mortality studies that give us numbers on death that's associated with anesthesia. It's kind of morbid as that sounds, but we do see that there are certain breeds that are at a higher risk for that. Rottweilers are at a high risk. The West Highland White Terrier, which I'm sure Alice has seen plenty of in her career, and then shepherds were at increased predisposition. And so we need more work to figure out what it is about those dogs that might result in an increase in I think in mortality or in death. And I think we have the speculation, we just don't have necessarily the numbers. We definitely know there are other animals where we have just documented that there is difficulties. Collies, for example, can possess another genetic abnormality that prevents them from being able to metabolize certain anesthetic drugs appropriately. So we have to be thoughtful about what we use for them. But I think what is equally as interesting is the dogs who are not predisposed to an anesthetic risk that we sometimes hear. For example, as we were talking about with small size, sometimes small breeds, people will say, oh, well, you know, I have a Yorkie and they're very sensitive to anesthesia, or I have a, you know, another name of a small breed animal and they're very sensitive to anesthesia. And again, any animal can have individualized reactions and responses, but as a breed, unless they have an underlying genetic or physical abnormality, for example, Yorkies are predisposed to having liver shunts, which is where the blood doesn't appropriately go to the liver to be processed and to clear things. Unless they have an underlying disease like that, they're not at an increased risk per se as compared to other things. Now, the one kind of fun fact is that we do see one purebred dog that is not at increased anesthetic risk, that actually has less of an anesthetic risk compared to mixed breeds, and that is the Cocker Spaniel. So if you're going to invest in that Dr. Alice will have many more patients.
They have problems everywhere else, right?
And brachycephalics. The important thing is that as a team, we look for the risk factors before we get started. And because we find out the risk factors with whether it's a genetic test or my exam or the blood test results or the cardiac evaluation, we're prepared. And we don't, and the drugs and what we use depends on what we've prepared for. So every anesthesia is customized to the patient. And so what we're decreasing is our chance of complications because we prepared with known risk factors. And I think the comforting thing for the pet owner is we can still provide anesthesia. And if we can't, we say we just can't. And that's pretty rare. But even with those known risks, we can still provide safe anesthesia.
Well, having said that, for example, Janet well, we're all pet owners, okay, but Janet as a non-veterinary person, what does she need to tell you about that pet's habits that could influence what you two are going to do? Like, is it a vomiter? That kind of thing.
I actually have, you go to the doctor's office and they give you 6 pages of your family history to fill out and, 6 pages. Well, I actually have a 2-page questionnaire before I see the pet. And one of the questions is, does the pet do any vomiting? And if they do, when do they do that? I want to know if they're vomiting at night. And I want to know if they're vomiting first thing in the morning before they eat. What I'm really looking for is regurgitation. So vomiting is an act of retching, and regurgitation is just it comes up. And it's usually bile. It's yellow bile. And these dogs and some cats have reflux or regurgitation. In people, it's called GERD, gastroesophageal reflux disease. And those are frequent questions that I ask because there's quite a high percentage of our pets that have that. The last I heard, it was 30%. I think it's higher than that. Dr. McKune can tell you. And once I know that, I actually dispense some medication to be given at home to help prevent that reflux during anesthesia and for a few days later. Because it's actually the fasting time, the time you give the last meal to the anesthesia, that fasting time, the length of that fasting time increases the chance of that reflux. So we have a very short fasting time now. But that's important to know.
I heard that. And that's kind of contra to what we were raised with.
That's right.
In our early years of vet school. Isn't that interesting?
That's right. So I actually have a handout because everybody that grew up with pets remembers, oh, we withhold the food for 24 hours and withhold the water. And I'm thinking, no. So I have a handout because you want to go back to what you've been doing for decades. It's tradition. It's what you remember. It's what you're familiar with. And I make sure they have that handout, how to prepare your pet. So I can answer any questions that can come up after the exam, but we're trying to prevent that. And it's quite frequent, but we can manage it. We can manage it.
What about these little Yorkies with tracheal collapse?
Mm.
I mean, that I would be worried about that as an anesthesiologist.
So that's another thing that you can hear often from the owners where, I mean, we sometimes hear it in the room when we have patients who have really bad airway abnormalities, and so including LARPAR as well as tracheal collapse. But the owners will be the ones who might say, like, he does a lot of like a honking type of cough, or he does a lot of, he's had a recent voice change or those kind of things. When we hear from owners that there's been something in the respiratory system that could be also related to the heart in some cases when it comes to coughing, we want to know more about that kind of information, because anatomy is one thing that we cannot change in the scope of a oral procedure coupled with anesthesia. There are surgeons out there who can make anatomical interventions. For example, the tracheal collapse we were talking about, there's methods where they can place something to help open the trachea up. That's not something Dr. Hoffman and I can provide in our practice. And so whatever abnormal anatomy that animal comes with is going to be something that, especially in the post-operative period, that period after they've recovered from anesthesia, but they're not necessarily back to their normal level of activities, those kind of things that are changes to the airway can be pretty significant. And so a big part of that requires us to be very vigilant and to monitor them in that post-operative period. But if we know those things are present beforehand, even in some extreme cases, we might recommend that it's a better idea for us to keep that patient hospitalized overnight at an ER that can make interventions rather than them go home with the owner. And so I think, are starting to realize that we can have a great anesthetic event, but when we can't alter the way the animal comes to us physically, we have to be very thoughtful about how that animal will be in that immediate post-operative period.
So as a pet owner, I'm going to bring my pet in to have surgery or to have dental work done. What am I supposed to do at home? What do I do afterwards? What can I expect in my pet, in the average pet?
You want to address just the anesthesia part of that, Dr. McKune? Because that's
Yeah. So one of the advances we've made in veterinary medicine that I think is wonderful is that we do anticipate, because we can't verbally necessarily reassure a pet. For example, even though they might walk into the veterinary clinic and we might say, everything's fine, they pick up on all of the cues. They pick up on the owner being stressed to be there. They pick up on the other animals in the exam room that are stressed to be there, on all of the scents and everything. So we have started to prescribe in advance of anesthesia medications that can take away a patient's anxiety. So as a pet owner, your veterinarian may ask you to preemptively, the night before, the morning of, or both, administer one of these drugs that helps with anxiety. And that way, when they present to the hospital, they come in less anxious than they could be. That sets the tone. I had an anesthesia mentor who used to tell me that the golden rule of anesthesia is thou shalt not upset thy patient, and so by bringing them in already having a certain degree of calmness, the owner has done us a huge favor by making that patient more comfortable with the whole process. That allows us to reduce the amount of pre-medications that we have to use and the other support measures. Once we've completed anesthesia, we do usually want to keep the pet for the first 2 to 3 hours. And so sometimes it can seem like, wow, my pet had a procedure that went all day. And in reality, the procedure itself may only have been an hour long, but the veterinarian wants to keep the animal so that they can make sure there's no problems. Because we do see, depending on the study you look at, that mortality afterwards, in other words, an animal passing away after they've woken up from anesthesia, is anywhere between 47 all the way up to 83%. So they make it through the anesthetic event without complication, but in the post-operative period, which can be up to the first 48 hours, they pass away. And we take those things very seriously on the anesthesia side. It's something that we want to hear about from owners. And so if you are an owner who does have a complication, sometimes as minor as he was vocalizing all night, or, my pet has passed away. We definitely want you to reach out to us and to let us know. Normal, average pets, the biggest things you'll probably see are patients who are going to have that delay back into their normal return to function. Sometimes they feel so comfortable after anesthesia, they want to eat right away. Sometimes because of the anesthetic agents themselves, they aren't interested in food. So that first night, we do tell people to allow the animal to make the choice so that they can, if they're not ready for food, we're not forcing it on them. And then we want to try and make sure we send you home with some pain medication to make sure it's not pain or discomfort that they are not eating because of. By the next morning, they should be moving back into the normal eating routine. But we do see that it takes sometimes 2 to 3 days for them to return to those normal bowel movements that we talked about earlier. And that's because anesthesia, if we're doing it right, slows everything down, And so that slowdown means that we may see a patient who normally goes to the bathroom outside every morning at 8 o'clock. We expect them to urinate normally, but if they don't defecate, then that's not something that we're surprised by. But it is something that can be really disturbing to the owners when they're used to a regular. Right.
And then the senior or the very old, the geriatric patients can take even longer than a day. It could be like 3 days before they're back to their self.
Yeah.
And don't the pain medications slow that down as well? Slow down the
GI tract.
Yeah, depending on what we send.
Certain ones. Yeah, certain ones.
I've always wondered if when they come home and they want to eat, and so I say, okay, and then they throw up. Do I need to call you about that?
So sometimes they don't want to eat because their mouth had a lot of surgery, or maybe they took a part of the jaw off. There's some, so there's different things, but I always say, and I think Dr. McKune will agree, that we only have them give a small portion of a meal the first night, because we don't want them drinking a whole big bowl of water and eating a big bowl of food, because they're probably hungry.
And that's where they go. They go right to the food and water bowl as soon as they get in the house.
And that's too much. So we always have them give a portion of a meal and small amounts of water. And then the next day, back to normal volumes of food and water. But if they had oral surgery, it's going to be soft food for a while.
So keep them on the hungry side, so to speak.
Yeah.
Okay. Yeah. I always worry about that. Even with us, when we have procedures. And we come home and like, geez, I wonder if I should eat. Because, like colonoscopies and things, you haven't eaten for, it seems like weeks. Do a lot of, or I shouldn't say a lot, but Janet had a family member that had a procedure and then vomited and aspirated.
Yeah.
Does that happen a lot, or because they're intubated, we don't see it?
That's the reason we want to know if there's any vomiting at home during the night and in the morning. The regurg patients. I have seen regurgitating patients vomit through their nose during anesthesia because we didn't know it was a regurg patient. So that's, but there's what's the percentage now, Dr. McKune, that we're thinking?
Like Dr. Hoffman was saying that part of the history is real critical, because what we find is up to 50% of animals, 1 out of every 2 animals, if we have something that evaluates for a change in the pH in your esophagus, so the long tube that connects your mouth to your stomach, if we look for change in pH, we'll see a drop in pH as stomach contents move forward, which are normally kept out of that tube. And so they may not, even for us, even Dr. Hoffman and myself may see nothing, but if we have a pH meter in them, we'll see 1 out of 2 patients will have a change in the pH, indicating that stomach contents are moving forward. And then what we are worried about is if they move forward far enough up into the mouth, there's another tube there. And there's, as we like to jokingly refer to with my husband, who's also a veterinarian, the eating hole and the breathing hole, And so that hole that connects them to their lungs, which is where we place the endotracheal tube to keep that safe, if they get fluid far enough forward, they can move that fluid down into the lungs. And so we keep a tube in animals. So people will sometimes ask, does my animal have to have this tube? Yes, they have to have the tube to protect the airway, but we can't keep that in them forever, right? And so as soon as they're awake and they're starting to come around, no human or animal really loves the idea of something placed within their space to breathe. That's very foreign. It's very natural for us to cough when we get something down in our trachea, and they don't like that tracheal tube. So we have to pull that at some point. And then if that animal becomes more relaxed and they've had this regurgitation, they can aspirate that fluid. And the biggest concern about that is that fluid is a very low pH. It's very much acid, and so that acid will burn the inside of their lungs and their trachea, which sets off a whole series of events that can often lead to a patient requiring major veterinary support, which usually is at what we call a tertiary level, meaning we'd be at a referral specialist. Most veterinarians don't have the ability to deal with that. And it is something that can also end up in a patient that dies afterwards from everything. So we want to be preemptive then. So as Dr. Hoffman said, if you tell us that this patient is, has these things that after a long meal, they bring up some bile and some fluids, we're going to preemptively have the owner start on things to neutralize the stomach pH, because anybody who's accidentally swallowed water down the wrong hole knows that, it's irritating, you cough, you get it out, and then you go back to living your normal life. If you can imagine drinking a thing of bleach down your lungs, you would probably not just cough it out and go back to a normal life, And so if we know those things in advance, we can have things that will help to neutralize the pH. We do give things during the anesthetic procedure regardless to neutralize stomach pH, but there are some drugs that do a way better job than others, and so we can give the better drugs in advance. The ones that we give during the procedure are ones that are meant to act quickly to reduce pH, not necessarily to be the best, but to act very quickly with all that. And then we also employ other things that might help to keep things moving forward, so that we don't have fluid that's brought up and that. So we can never fully prevent something that's passive, like a regurgitation, but we can mitigate the side effects that might happen with them.
Wow.
You know what I love about what the two of you do together? So much in human medicine, Janet, I think you would attest to this, is like factory farming. They try to act like it's personalized, but it truly is personalized and geared toward each individual patient, what you both do. And actually what I did as a dermatologist too, there's no two allergic dogs that are alike, no two allergic cats, but I so appreciate you taking each patient as an individual, because isn't that what we all want for ourselves, not to mention our pets? And I think dentistry and anesthesiology is still wonderful because of that. We're so lucky to be practicing with such good individualized patient care.
Well, I really learned a lot about the safety of anesthesiology, because as a general layman pet owner, you hear all this around you of, they knocked him out for 5 hours and it's not all true. Now I know that there's that recovery period, and I know when I've had to go under general, it's not so bad, It really isn't. And you're up and you don't remember a dang thing and everything's fine.
That's because you had a good anesthesiologist.
That's right. That's right.
Well, we really appreciate you too.
Wow, but this has been wonderful. I've learned so much. Janet, we have to have them back on again.
You have to have you back on. But we have a question for Dr. McKune and Dr. Hoffman. Tell us what your pet or human peeve is, please.
All right. I'll start because I've been doing some reflection on all of that. And I think my biggest pet peeve, it's going to sound very cliche to say this after this episode, but is when people don't advocate for their own patient. And I don't mean that they do that out of carelessness. I mean, it's not that they're like, I don't care what happens with this animal, but when they feel bullied by the staff, when they feel like they don't get along with the veterinarian, and they just accept that this is what it has to be. Because as Dr. Hoffman and I do work so closely together, we're blessed to have a wonderful relationship, and we are oftentimes sought out for people who are advocating for their own animal. And yet I know many other times where animals have had a complication and somebody says, I wish when I'd said this, somebody listened. If you feel like someone is not listening to you, there are veterinarians that you can reach out to. It's a wonderful thing for your animal to have that same kind of good quality relationship with your veterinarian that you have with a good friend. And I feel like that's Dr. Hoffman and my relationship. We've been on the phone together several times this week. We collaborate on things, and that synergism allows the best outcome. And so if you don't feel synergistic with your veterinarian, it's important for you to maybe evaluate other veterinarians in the area that you might have that same relationship, so that the animal can succeed and can do really well. They need that from you.
That's great advice.
And can I cut in before Dr. Hoffman? Can I just say this? It's because you both care. That's what it comes down to. You both care. And I'm sorry, Dr. Hoffman, you go for your pet peeve.
What's your pet peeve?
I'm so impressed by the caring and devotion. It's wonderful.
You know, Alice, they went out to lunch together and they were probably talking pet peeves.
Well, it's hard for me because I struggle with that. So mine is not going to be as poignant as Dr. McKune's. I don't like when fast food isn't fast.
Oh, step on it.
That's it.
Okay, name names.
No, I don't do that.
And being a vegetarian, I hardly ever eat fast food because there's
doesn't have to be
nothing
hot.
There's some great fast food
There are.
vegan or
Where? Well, anyway, this has been so great. We hope you'll join us again. I loved every minute. I was like just counting on every word. I just love, you remind me of me and how caring, and it's just, that's what I love about veterinary medicine. People like you.
And
seriously.
I think we have some human owners that need that Valium prescription before
Yes, it's true.
Oh,
It's true.
absolutely.
whatever it is they give you.
Yeah.
Whatever it is. Yeah.
Yeah,
Or
but I will
Ativan.
tell you that we talk to all owners, and we do tell them afterwards that, as the patient is being anesthetized, they need to take a moment and give themselves a little bit of grace, because it is hard to get your pet to that point where they're ready. And sometimes the hardest thing in this society is to take a few minutes to yourself and reward and congratulate yourself for putting all that work and effort in, and then to maybe give yourself a moment to breathe. Yeah, so you're right.
Janet, you started with a story about you going to the dentist and getting stuff, and you wish you had sedation. And this is true. People want anesthesia or sedation for themselves. Just don't want it for their pet. So
That's true.
Yeah.
Well, thank you both. We appreciate
Oh my gosh,
Thank
Janet, I think we'll wind it up, but we haven't seen the last of this dynamic duo. I'm telling you right
Not at
now.
all. You need T-shirts, Dynamic Duo.
I know, we love
I see the
them.
logo already. Like knock them out through their teeth, knock them out, sew up their jaw.
That's right.
Yep, we call Dr. Hoffman the Tooth Fairy. I'll be the Sweet Dreams Fairy. We're the fairy team.
Anyway, we're going to close it out. This is Dr. Alice Novotny-Jeroman and
Janet Novotny King saying thanks for joining us. We're in the Novotny Sisters from good old Cleveland, Ohio. Thanks for listening. Don't forget to follow us, like us, and see you next time. Thanks for listening.
bye-bye.
Hey, thanks for watching
And listening,
We like likes.
Don't forget to like, share, and subscribe. You can follow us on social media at Speaking of Pets.
and give your pets a big kiss from the Novotny Sisters.
The Speaking of Pets podcast is an SLA video production.